Hi, this is John Kanellopoulos from our office here in Athens, Greece. It's really a pleasure to describe to you this very interesting case. This is a 11-year-old young girl who had this very severe penetrating trauma to her cornea and her lens. She has a phakic with this very severe scar. There's vitreous and iris synechiae to the scar. Vision is light perception. Fortunately, we have the Optos device show us that the retina is intact. Optic nerve macula is fine, and we're going to explore a little bit with our anterior segment OCT, the Vanti by OptoView. The condition of the cornea, you can see here clearly the scar that is slightly paracentral. You can see here the iris synechiae that was sutured within the cornea scar at the time of the primary repair that was done elsewhere. Again here, more extensive synechiae. Fortunately, there's no macular edema despite the fact that UVA is attached, and here a few more images describing the condition of the anterior chamber. Of course, the cost of the cornea is very significant. This is the placido disc topography showing the very significant irregularity in the cornea. Although centrally the astigmatism, one can say, is relatively regular. And then the other task is to obtain axial length measurements. We see here the central keratometry by the Tomei device, and then our lens star axial length measurements. And by comparison, the other eye, they're not that much off, 23.67, so a slightly hyperopic eye. And then again, measurements of the axial length here with ultrasonography. And we planned to put an iris fixated lens, an Artisan lens by Optic of the Netherlands, to be placed retropupillary and use the lens as a pupilloplasty or iridoplasty device. Very difficult to ascertain what power lens we aim to make her myopic. And this is her in the OR just after she was put to sleep for general anesthesia during this procedure. We're going to perform a conjunctival peritomy here. You can see the conjunctiva is scarred. It was probably involved in the initial trauma as well. We can see how dense the cornea stroma is from the scarring. We recently had to treat primarily a similar case on a similar age young lady who had a penetrating cornea and lens injury. And we're going to describe that in a different video, how careful we are in resuturing this and how careful we are in removing the sutures. So after peritomy, we're marking 6 millimeters here to create a scleral tunnel. Very important, in my opinion, with these lenses not to go with a cornea incision because a blunt trauma can blow the incision open and again have more significant complications. Going back to our stromal and scleral pocket technique, we'll create an incision that will withstand most of the significant impact that a young lady may have while playing or during sports, etc. We're trying to bring this young girl back to a normal lifestyle. So again, with our crescent blade, we're going in here creating a nice scleral pocket and then into the cornea stroma to create enough leverage for this to be watertight. We're going to enter with our keratome, and now we're going to start lysing the synechiae between the iris and the cornea. We're very careful not to injure the cornea. Viscoat was used to fill the anterior chamber here. We're releasing some of the synechiae, and further down the line, I'm going to go in with a Sinskey hook as a second point of fixation in order to stretch the iris, and with my keratome try and shave it off, staying, of course, away from the cornea as much as possible. Alternatively, Van Ness scissors would do a similar job, but this trauma has been there for over a year. Fortunately, the eye has not turned exotropic again. This is an 11-year-old girl. We're in the OR at Euroclinic Athens under general anesthesia. And I want to thank the brilliant anesthesiologist, Dr. Costadara, one of our best female anesthesiologists in the pediatric team there. And now I'm going in with my vitrector to lyse all the vitreous bands that were attached to the iris and the cornea and start to compartmentalize the eye. separate the posterior chamber from the iris in the anterior chamber, we're going to use mycold to attain meiosis and more viscoelastic over the iris. As you can see here, more visco, push the iris back. This is the phakic Artisan lens. We're of course using this off-label in a pediatric patient. We're going to flip the lens backwards, and it requires a special formula. And again, as I mentioned in our initial data, you can go back to that. We planned her to be about a -2 myopic in case we plan therapeutic treatments to clear some of the scar, which is central, and they would be mainly myopic treatments. So here is the lens flipped upside down. We're going to go through our scleral incision, and the enclavation needle is placed through a small clear cornea incision in place. We're going to use the lens as a means of iridoplasty, and here we're enclaving the haptics of the iris claw lens, or the Artisan lens. Tribute to Professor Wurst. I had the privilege to train with him back in the mid-90s in Groningen, the Netherlands, and learned from him this technique firsthand. Of course, the lenses were then implanted over the iris, either in aphakia or as a phakic IOL correction. And then following that, I was privileged to be involved in the FDA trials for the what was called Verisize lens then. So here we're using our lens forceps to place the lens behind the iris in the second haptic as well. Holding the lens with the left hand, right hand now has the enclavation needle. Tilting the lens a little bit so I can see the haptics under the iris. This is not an easy maneuver, and I'm going to try and enclave iris into the claws of the lens. You can see how nicely the lens now is oriented. It's holding my iris together at this oblique axis, and we're still left with a huge area of iridodialysis. So as a next step, in order to attain as much as possible normality in this young patient, we're going to use 10-0 proline suture and a long needle, going through the scleral incision to grasp the first lip of the free iris traumatized during the penetrating injury. You can see my needle now in the posterior chamber. It's gone through the first lip of the iris, and now I'm bringing the needle in from behind, anteriorly, and through clear cornea. I'm going to use my 0.12 forceps as counterbalance to exit the eye at the limbus. And again, very careful here to pull in on the axis of the iris, and then the tedious procedure to fish out the free ends of the proline suture. Throw the knots, again 3 knots, 3 passes on the first one and then single passes on the rest, outside the eye, and then use my long forceps. These are actually capsulorhexis forceps that I'm going to use to go into the eye and tie the knot. So again, very careful maneuvers here, not to pull off the iris. Last thing we want to do is cause more iridodialysis. So you can see how we were carefully pulling both ends of the proline suture and attaining a very nice pupilloplasty and iridoplasty. This is the third knot here. Again, same maneuver. The proline suture may thin out through the years, but reapproximating the iris will create synechiae that usually hold for the duration. And again, our pupilloplasty and iridoplasty is completed. We're going to trim the proline suture with Vanessa scissors, and then our scleral incision is watertight. Hydrate the corneal wounds and reoppose the conjunctiva with bipodal cautery. The longest part of the procedure was lysing the iris synechiae, the anterior vitrectomy. The lens placement was pretty easy, and then the iridoplasty. Here's the eye right at the end of the procedure, and this is the patient 2 weeks later. We're already at 20/40 uncorrected vision, and at near we're at J2 on the Jaeger card. The mother is ecstatic. We're going to share some pleasant moments. These are the highlights of our work. Makes it all worth it. Mom and daughter, very happy. This is John Kanellopoulos. Thanks so much for taking this journey with me through this very difficult and challenging case. Signing out.